Hi, welcome to our presentation titled Age-stratified severe and critical infection rates to estimate COVID-19 under-ascertainment by Daniel R. Espósito, Paola Darmolén, and María Inés Fariero. The under-ascertainment of SARS-CoV-2 infections is a common problem because of the diverse clinical manifestations of the infection and the limits of testing and tracing capabilities. However, under-ascertainment interferes with epidemic evaluation and control, and therefore it is desirable to try to estimate this quantity. Because COVID-19 deaths are expected to be mostly identified, COVID-19 death data may be used to estimate the total number of infections and under-ascertainment if we assume a lawful relation between deaths and infections, despite fatal infections being only a small fraction of total infections. In line with this, in a work published in BMC Medicine 2020, Russell et al. Estimate under-ascertainment of COVID-19 from observed deaths. For this, they employ a model of expected daily deaths using the case fatality rate from the literature, CFR, which is a known quantity in the model, the daily reported cases at each day t, which we refer to as C sub t, which is also a known quantity in the model obtained from observed data, a diagnosis to death delay probability distribution, P delay D, which indicates the probability that a delay D between diagnosis and death will occur in a fatal case, and finally the daily ascertainment rate, A sub t, which is the unknown quantity that we wish to estimate. Then all these quantities are put together to estimate the expected number of deaths at each day D. These are obtained by adding for all the previous days the number of cases reported in each day multiplied by the inverse ascertainment rate for that day, which together give the real number of cases estimated for that day, multiplied by the case fatality rate, which altogether give the expected number of deaths coming out of this previous day, and finally all this multiplied by the probability of the delay t, which gives the number of these total deaths coming out from this day that are expected to occur in day D. This model also accounts for uncertainty in the baseline case fatality rate by using a Gaussian distribution of possible values. Also, the daily ascertainment rate, A sub t, is modeled with a Gaussian process which gives it smoothness in time, as shown in the formulas below. Finally, the daily ascertainment rate, A sub t, as well as the uncertainty around this parameter, are estimated by fitting the model to the observed daily deaths using Bayesian methods, where we assume that the deaths observed at each day follow a Poisson distribution with parameter equal to the expected number of deaths for that day obtained from the model. This procedure allowed Russell et al. To estimate the ascertainment rate and the real number of cases for different countries. Below, an image reproduced from Russell et al. Shows the reported number of cases in black and the number of real cases estimated with their method in blue. However, one limitation of this method is that it requires a sizable epidemic to work because of the small fraction of infections that result in death. This makes it uncertain whether the method can be applied to stages when the epidemic is relatively under control and with low numbers, as is the case of Uruguay for most of 2020. Here we see that for most of 2020, up to late September, Uruguay had below 50 cumulative deaths. One way to circumvent this issue, however, is to use outcomes other than death for the estimation, such as the number of severe cases defined as cases requiring hospitalization. We see in the plot to the right that the cumulative number of severe cases was 3 times larger than the number of deaths up to late September in Uruguay. Another issue that may particularly affect small epidemics is that the outcome rates may change in time as the epidemic changes. One relevant cause of this is that the age distribution of infected individuals may change in the course of the epidemic, and the outcome rates depend strongly on age. For example, the infection fatality rate increases exponentially with age, as shown in the plot to the left, extracted from Levin et al. As an example, we show to the right the average infection fatality rate estimated with the age distribution of the reported daily cases in Uruguay and the fatality rates reported by Levin et al. We see in the plot to the right that the average fatality rate changes close to fourfold in time during the early pandemic. Therefore, to better apply the method from Russell et al. To smaller and changing epidemics, we first estimated age-specific rates of severe and critical disease among infected individuals. Then we applied Russell's method to reports of severe and critical cases, besides deaths, using the average rates of severe and critical disease as fixed outcome rates. Finally, we extended the method to use varying outcome rates for the three different kinds of outcomes, which were estimated from the time-varying age distribution of the reported cases. For this, we modified Russell's method as follows. Instead of the expected number of daily deaths, we estimated the expected number of severe or critical outcomes. This was achieved by substituting the rate of fatal disease for the rate of severe or critical disease, as well as using the delay probability distribution for this new outcome. Also, we used a time-varying outcome rate, which consisted on the average outcome rate for the age distribution of each day's reported cases. These were estimated using a log linear relation between the outcome rate and age, with parameters estimated in a procedure that we don't show here. The uncertainty of the slope and the intercept of this log linear relation were also included in the model. Next, we applied this model to the epidemic data of Uruguay between November and January, when the country lost control of the epidemic. This loss of control included a steep increase in the total number of deaths, as well as increases in the proportion of positive tests, which suggests an increase in under-ascertainment. Here, we see the estimated percentages of ascertained infections, adjusting the model to reported deaths, critical cases, or severe cases, all while using fixed outcome rates. We see that the model fitted to the death data shows a drop in the estimated ascertainment rate in the same period when Uruguay lost control of the epidemic. However, this change is not seen when fitting the model to the reported critical and severe outcomes. Now, we show the percentages of ascertained infections estimated with variable outcome rates. Interestingly, we see that the results do not change much compared to the fixed outcome rates. This is contrary to our expectation that considering variable outcome rates should improve the estimations. Therefore, we wonder what may be the explanation for this lack of an effect. We noticed an interesting pattern in the data. The average fatality rate estimated from reported cases data, which reflects the underlying age distribution, falls in late November, but then it increases substantially in December, when testing capabilities got severely compromised. This is counterintuitive, since we may expect elder people to take greater precautions when the epidemic is getting out of control, which would lead to a fall in the average fatality rate. One explanation for this observed increase in estimated fatality rate is that, because under-ascertainment is expected to be biased towards younger individuals who show milder COVID-19 cases, an increase in under-ascertainment in December could bias our estimated infection fatality rate upwards, so that our estimated infection fatality rate would not be representative of the real underlying age distribution among infected individuals. To test our hypothesis, we plotted the relative change in estimated IFR using the age distribution of reported cases in red, which are expected to show increased under-ascertainment, and using the age distribution of fatal cases in blue, which are expected to have low under-ascertainment at all times. In line with our hypothesis, we see that the IFR estimated from reported cases increases more than 40% in December, while the IFR estimated from fatal cases remains largely unchanged. This observation suggests that using the reported case data alone to estimate the time-varying IFR may bias our results, preventing the method from improving the estimation of under-ascertainment. In conclusion, the estimation method captured a decrease in ascertainment during the loss in epidemic control in Uruguay when adjusting to death data, but not when adjusting to severe and critical cases data. This may reflect differences in data quality for the different outcomes or an advantage of deaths over milder outcomes for this purpose. The use of time-varying outcome rates estimated from case data did not change the estimated ascertainment. This may reflect biases in case data that affect our outcome rate estimations. Other methods of estimating the varying outcome rates may improve the method. This work is part of efforts of the group Guiad COVID-19 to aid the pandemic response in Uruguay. This work was supported by a grant for COVID-19 research from CSIC UDELAR from Uruguay and by the Centro Interdisciplinario en Análisis de Datos y Aprendizaje Automático, CICADA from UDELAR. Thank you for your attention.